Welcome, everyone, and thank you for joining this afternoon's webinar. We are thrilled to have Dr. Richard Zimmerman here to share information about Teflon granulomas after having an MVD. Whether you are directly impacted by facial pain or simply interested in learning more, we're grateful that you've taken the time to join us today. My name is Brandy Underwood, and I serve as the Development, Research, and Advocacy Manager for the Facial Pain Association. Before we begin, I would like to share some exciting updates from the FPA and go over a few housekeeping items. On February 28, 2025, the FPA will join the global community in raising awareness about rare diseases. Launched in 2008, Rare Disease Day is a grassroots campaign led by people and patient organizations that bring together millions worldwide. Having a rare disease can be isolating for the nearly 300 million people living with one of the more than 6,000 identified rare diseases. Throughout February, the FPA will be sharing facts about facial pain on social media. Please feel free to share our posts on your personal social media as we work to educate others about rare diseases. We hope you'll join us in spreading awareness this month. On February 28th, if you feel ready to share your story, please tag us so we can share it too. Now, to go over a few housekeeping items. If you have any questions, please use the Q&A feature at the bottom of your Zoom screen. We will have a dedicated Q&A session at the end, but please feel free to submit questions throughout the presentation. For this presentation, we ask that you limit your questions to one per attendee to ensure we answer as many questions from as many attendees as possible. We encourage you to connect with others who have joined today using the chat feature. Today's webinar will also be recorded and available on our website in approximately 1 week. Now, it is my honor to introduce this afternoon's presenter. Dr. Richard Zimmerman is a professor of neurosurgery at the Mayo Clinic College of Medicine and Science and staff neurosurgeon at Mayo Clinic Hospital in Phoenix, Arizona. Dr. Zimmerman earned his BA with honors and MD degrees from Boston University. He completed an internship and residency in neurosurgery at Medical College of Virginia, Virginia Commonwealth University, followed by a fellowship in neurovascular surgery at Barrow Neurological Institute. Dr. Zimmerman's clinical work for over 30 years has focused on trigeminal and other cranial neuralgias, hemifacial spasm, vascular and skull-based neurosurgery, and epilepsy surgery. Dr. Zimmerman serves on the Medical Advisory Board of the Facial Pain Association and has championed innovations in the treatment of trigeminal neuralgia surgery, focusing on improving outcomes and increasing safety. Dr. Zimmerman has received exceptional recognition for his leadership at Mayo Clinic, being noted as a Mayo Clinic Distinguished Educator in 2022, Mayo Clinic Distinguished Clinician in 2024, and receiving the Mayo Clinic Lifetime Achievement Award for Quality Improvement. Again, we are thrilled to have you here and hope this session is helpful for you. Without further ado, let's get started. Dr. Zimmerman, please take it away.
Well, good afternoon, Brandy. Thank you for that wonderful introduction. Welcome, everyone. It's a delight to be here. Thank you, Ms. Bombeck and the FPA team for having me here to speak today. Let me share my screen so we can get started and have time for both presentation and questions. And Brandy, give me the high sign if this looks good.
Looks fantastic.
All right, very good. So I'd like to explain where this presentation has its origins. And basically, I began to wonder about the use of Teflon for microvascular decompression. And if you've been with the FPA for a while, you know, this is not the first time that I've brought this up as a option of things to consider as we work to improve the care we give patients with facial pain. You know, I'm always looking to do things better, to potentially explore ways of doing things differently, because we certainly haven't got trigeminal neuralgia figured out. We certainly haven't got all the aspects of facial pain figured out, whether it be treatment with medicine, treatment with procedures that palliate, or treatment with procedures we hope cure. We're still looking for answers. And I think if we stop looking, it's a failure. So with that mindset, I began to look at what happens after a Teflon MVD in patients with recurrent pain. And that there is a pathological response that occurs, and we'll go through that Although this is the title of where I began, I think most of you probably have more of an interest in seeing what is exactly this Teflon granuloma that Zimmerman talks about, or that anybody talks about, because I'm certainly not the first nor the only one that's brought up the issue of granuloma when Teflon is used, whether it be in MVD surgery or other aspects of healthcare. And we'll go into that in a little bit. So a couple of quick things. I work with a great team that comprised of colleagues, residents, nurses that are amazing, allied health practitioners that are fantastic, interventional neuroradiologists, radiation oncologists, wonderful neurologists in both headache and general neurology, neuro-ophthalmologists, and neuropathologists. Without them, I would be nothing. Some simple disclosures, although none have anything to do with any financial benefit from this presentation or this topic. So I really need to start with this really important level-setting statement that trigeminal neuralgia is a condition that is incompletely understood. If anyone tells you they really have it figured out, it's time to go out the door and find someone else to talk to, because we really don't. There are patients that have vascular compression that have no pain. There are patients that have no compression and have pain. The whole entity of what's the exact mechanism is still being explored. That's why there's research ongoing in many domains for trigeminal neuralgia and the patients suffering with facial pain. And this also underscores our assumptions about facial pain, and they are just that. They're assumptions, there's some good educated guess, there's some research, although as one of our previous medical advisory board members, Dr. Zakshevska, talks about, the way that we analyze trigeminal neuralgia has lots of faults. So we need to take everything with an open mindset that really looks at, is this really accurate, or at least we can say it's the best we understand at the current time. So for today's talk, I'll go through some objectives, and please pay attention. There will be a test later. No, I'm just only kidding. I want to provide an overview of what a foreign body reaction is to biomaterials as a clinical phenomenon. And I'll explain all those words as we go through this. I'd like to illustrate the relevance of these concepts in the surgical treatment of trigeminal neuralgia, specifically the procedure known as microvascular decompression. I'll present imaging, intraoperative findings, and clinical pathologic correlation in a case of recurrent trigeminal neuralgia after MVD with Teflon. Actually, I'll present a few cases, or a few images at least. And then I'd like to elaborate on the adverse microenvironment that exists in this foreign body reaction with multinucleated giant cells. And I'll explain all these terms, which is what we see in Teflon granuloma formation. And then I would obviously close with posing the question of, is there some option or opportunity for technical or technique refinement in trigeminal neuralgia surgery, such as a Teflon-free technique for microvascular decompression? So as we do in many clinical conferences, we start with a little vignette of a patient. This is a 54-year-old patient who had an MVD in 2008, that after 6 months had recurrence of the same pain as at the beginning. She underwent 2 radiofrequency rhizotomies. These are destructive thermal injury procedures. They both failed. She continued to have pain. She underwent a radiation procedure known as gamma knife radiosurgery 10 years after her MVD, which also failed. And then she underwent a 3rd radiofrequency lesion. And she continued to have problems where she did not have any burning pain. So for those of you who know what anesthesia dolorosa was, remarkably, after 4 ablations, 3 radiofrequency and 1 gamma knife, she was still free from anesthesia dolorosa. She had typical triggers of precipitated attacks of electric shock-like pain with any facial contact or stimulation. And she did have facial numbness, which indicated she did get some true effect from any of the rhizotomies. She had an exam that showed deficits that you would expect after multiple rhizotomies, decreased sensation in the face. She also had some asymmetry, which is an interesting aside of the potential risks of surgery. And then, again, the weakness was manifested as slight asymmetry of her smile. Her imaging showed atrophy, although I'm not exactly sure how the radiologist interpret atrophy, and you'll see why, of the trigeminal node on the treated side. There was a mass or foreign body present, likely Teflon, given the operative notes, and then perhaps a Teflon granuloma due to some enhancement. And that's a point of interest, although not of major interest for today's discussion. So let's start with her imaging. On the upper left, we can start with what's an axial or a cross-sectional view from the top down of the pons, the trigeminal on the non-operated normal right side of the patient. And if you look at the corresponding left side, there should be symmetrical you can't make out the trigeminal nerve. You can't make out the spinal fluid space or the CSF space around it, known as the CSF or the cistern around the trigeminal nerve, because it's obscured by artifact, which in fact is a foreign material placed at the time of the first MVD. Similarly, if you look at a front view, the coronal section, this is the pons, this is the trigeminal nerve on the normal right side, and you really can't find the trigeminal nerve on the left side due to artifact from foreign material. On the lower right side of the screen, you'll see what we know as Meckel's cave. The face is over here. The back of the head is back on this side. Because Meckel's cave, this is the trigeminal nerve going to the pons. This dotted line represents the tentorium, a membrane that separates the posterior fossa with the cerebellum and most of the cranial nerves from the cerebral hemispheres. And I put these two things in, Meckel's cave as a reference point and the tentorium as a reference point, because when you look at the picture above, this is the surgical side from the side view. Meckel's cave, you can see, is about the same. The tentorium is about the same. But where you see a nice side view, if you will, sagittal view of the trigeminal nerve, you can't make out anything because of the foreign material. So this is the starting point of addressing this patient who has recurrent facial pain after MVD with Teflon and multiple procedures. Now, for those of you that have seen some of my work before and the presentations before, vascular transposition, moving blood vessels off the trigeminal nerve, can be done in many instances, even when there's a large vessel loop that descends way below the trigeminal nerve. And all these pictures, this is the trigeminal nerve, this is the trigeminal nerve, this is the trigeminal nerve, and all these vessels cross against and press the trigeminal nerve in various ways. You can see it being lifted off here, and again, finally here. The point of all this is that we are able to move the trigeminal nerve off. In this case, glue is used to keep it off the nerve. There are many different techniques. There's clearly no evidence that one is particularly superior to the other. But the key point is that Teflon is not mandatory. Teflon has no magical properties. It is not necessarily a requirement for treating trigeminal neuralgia with an MVD. And so Teflon-free MVDs can be done with aneurysm clips, with slings, with glue fabric or glue materials, things other than Teflon as well. So there are opportunities or options other than the use of Teflon. So why did I begin exploring Teflon? This is a left-sided approach for a trigeminal nerve decompression, an MVD, in a patient with classic tic pain. Here are two blood vessels, the two superior cerebellar artery branches. There's actually also a vein. All are compressing the region of the root entry zone. This is the facial and the vestibulocochlear nerve, the 7th and 8th nerves. The brainstem is down here, and this is leaving the root entry zone going up towards the face. This is a patient who's had an MVD with Teflon. You can't make, it's the same view, different patient. Here's the 7th and 8th nerve. Here's the 7th and 8th nerve. Here's the, well, there is no trigeminal nerve because it's covered by this piece of material. This is a piece of Teflon years after being implanted in this patient. And I want to go through what we see here. So during surgery, obviously, sometimes you can have a little bit of blood contaminating your field. Brain surgery optimally like to have it, especially when it's in the subarachnoid space like an MVD, essentially bloodless. But there's a little blood pooling here, and a little bit of blood is on the surface of this Teflon mass here. And you can see where the white arrows are. But under the microscope, if you look a little bit deeper, you'll see, as shown in the black arrows, little structures that are within the mass of Teflon and the tissue that has encompassed the Teflon. And you'll see what I mean by tissue in a few slides. I'll take a little close-up of this area here, and you'll see there's a linear structure, and I hope this broadcasts well enough to see, that looks like a little blood vessel. And in fact, we'll see that that's what it is going forward, growing and being formed within the Teflon and the tissue mass around the Teflon. So let's look at the foreign body reaction that I mentioned at the introduction. And we're going to start with the body's reaction during normal injury or during implantation of anything into the body. So if you cut yourself, have a trauma, or get an implantation of a pacemaker or anything else, there are a couple of standard procedures that the body follows, if you will, to heal. You initially have an inflammatory cell infiltration. Polymorphonucleated white cells, or polys, are the first responders, if you will, of the white cells when you have an acute event like injury or implantation. They respond to acute inflammation or the trauma caused by tissue damage, which releases chemicals that recruit these polys and mast cells. Mast cells release histamine. Histamine is a chemical that will cause inflammation, dilation of blood vessels, bringing more blood flow to help heal. Unfortunately, the mast cells also are mediated for pain, so you know something bad has happened. The acute inflammation evolves over time to what's more chronic inflammation, part of the healing process, and this is normal. And that's associated with other white cells moving in, monocytes and lymphocytes. The lymphocytes are associated with more of the immune response by humoral immunity, like antibody response, the B cells and T cells. Those are the lymphocytes. And the monocytes will respond because they act up as scavengers when they leave the blood system, and you'll see that they actually change into a different cell type or different nomenclature because of different behavior. All this leads to the healing tissue we call granulation tissue, and then fibroblast proliferation and migration. Those are the cells that form scar tissue. This is all normal, and you all have capillary formation to provide healing to that tissue. Fibrous capsular scar is the end result in the normal process for injury. Now, there's a slightly additional pathway that follows for any implanted biomaterial that gets inserted into the body. And you'll see that when you put something foreign into the body that's not organic, that's not going to be broken down by the standard process, you have a response mediated by inflammatory proteins. They're known as interleukins, and they respond by causing cells to come to the site of injury in a slightly different fashion than normal. And what happens is when you have interleukins respond and other cytokines, other chemicals that attract white blood cells, you'll begin to see other cells, monocytes, which we talked about before, migrating, but then they differentiate and they change their behavior and their morphology into what are called macrophages. And then you'll see these macrophages, which act like the Pac-Man of the healing process. They go and they scavenge up the debris of dead tissue, of tissue that's been broken down, so they can dispose of it. But in the presence of biomaterial that's not biodegradable, it's not biologic, it's not organic, any material like a piece of metal would not be broken down, or in the case of MVDs, Teflon, which is not broken down. The macrophages have a change in behavior, and they have an unusual aggregation methodology to respond to this Teflon or foreign material, and they form what's called a giant cell foreign body reaction, or foreign body giant cell formation. And we'll get to what that is. That's really known as a granuloma. Now, the chemical process here is one of the processes that occurs, and it's mirrored by a simultaneous cellular process. So those are the chemicals we talked about. Let's talk about the cells that behave to foreign bodies that are inserted into the human, or any of the living tissue for that matter, or at least mammalian tissue. So we start with the monocytes. When you get a CBC, or a complete blood count, when you go to the laboratory and they want to do a blood test and see how your blood counts are, monocytes are one of the components, like the red blood cells, the white blood cells, and the subtype of white blood cells. There are polys, there are monocytes, and there are basophils, eosinophils, or mast cells, other cells that can comprise the blood products. Now, the monocytes I already talked about, they're attracted by those chemicals, the interleukins and the cytokines, and it causes the monocyte, which normally resides inside the bloodstream, to migrate. Now, many people think about blood cells living in the bloodstream, but they actually migrate. White blood cells migrate outside of the bloodstream through tissue and the interstitial space, the spaces between the tissues of the body, and they get to the site of injury. So they migrate to the tissue, and they are no longer monocytes. They now become macrophages. The chemotaxis is the attraction by those chemicals. Migration occurs as they move throughout the body to the site of injury or inflammation, and they begin to stick and adhere because of those proteins, those interleukins, to the foreign material, and they differentiate into a macrophage. They change from monocyte to macrophage. This is the Pac-Man stage of life, if you will, of this blood cell line. And they attach themselves and try and break down the biomaterial. The problem is their membrane that surrounds all the macrophages recognizes that they're not doing what they're supposed to be doing. They're unable to engulf, if you will, or phagocytose the material as it's broken down, and they can't scavenge it, and they keep calling for more recruitments. And so there are more and more monocytes come to the site. They transform into macrophages, and eventually the signal transduction, which is the mechanism by which the membrane senses the environment, tells the nucleus something is weird because we're not doing what we're supposed to do. And they begin to change and morph into a fused tissue mass called a foreign body giant cell. And so many nuclei are in one cell, in one giant cell, and their activity is, again, to continue to try and exude enzymes that are going to break down the foreign invader, if you will, the foreign material. And they keep doing this as they keep recruiting more and more. They have what's called a phenotypic expression. If you think about a genotype, that's if you look at the genes that make up an organism, you can tell by the gene sequence what the organism is and some of its characteristics. That's the genotype by the gene composition. The phenotype is the physical expression of material in an organism, like the height of an individual, and in this case, the tissue mass of foreign body giant cells that are aggregated together into a granuloma. So I'll make this hopefully a little clearer in the next series of illustrations. So let's say some random nerve, let's say for sake, the trigeminal nerve, has normal blood vessels on it, has normal blood vessels near it. But in the case of trigeminal neuralgia, as most of you understand, the blood vessel is pushing on the nerve, and the classic operation to insert Teflon in between the blood vessel and the nerve is to separate the two. That's the decompression concept. So you have, in this case, a foreign material is inserted, and the body responds by having those proteins attach to this material. And there are proteins circulating in the spinal fluid, and they cause migration of those white cells, the monocytes, outside of the blood cell. They actually squeeze through little pores or openings. This phenomenon is called diapedesis, and they walk, and that's where the diapedesis comes from, so to speak, along tissue planes into the foreign body, and they attach themselves to the material courtesy of those proteins or the cytokines and the leukotrienes that are on the foreign material. At that point, they stick and they begin to differentiate into macrophages. And again, I talked about the macrophages being the Pac-Man stage of life of these white blood cells. They are sitting there trying to chomp, 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 eat up and phagocytose the material that's not felt to be normal in the body. The problem is when they can't make any progress and they're not getting rid of the material they're meant to get rid of, the membrane of the phagocytes recognizes this and it activates them to be a different behavior, have different behavior. At that point, they begin to fuse into a tissue mass comprised of multinucleated giant cells. So a few of the macrocytes, each one has a separate nucleus, but when they fuse into a giant cell, you have a multinucleated giant cell. And that's the essence of what a granuloma is. A piece of foreign material that have attracted monocytes that have transformed into macrophages, that have fused into multinucleated giant cells, and that composition together is a granuloma. So I hope that puts a little clarity about what we're looking or what we're talking about when we talk about Teflon granulomas. Now, let's go through some more examples. That's a nice illustration, but let's take it down to the level that's the actual functional level of what we do when we redo surgery for recurring pain in patients who have had a Teflon MVD. So this is a piece of Teflon. It's been removed after it's been in a patient for a number of years. The asterisk identifies the Teflon. This is a section of that under the pathologist microscope, stained to identify cells and nuclei. Each of these round, very prominent purple nuclei are nuclei of macrophages. As you can see, the asterisk here is on Teflon, and each asterisk represents one of the Teflon threads or fibrils that really is what the Teflon that we use is made up of. It's really a felt network of fibers, and individual level, at the microscopic level, you can see them separated out. But what's really important to recognize in the slide are the multinucleated giant cells that are associated with the Teflon fibrils. Where you see Teflon, you see multinucleated giant cells in the proximity, as well as individual macrophages that haven't yet fused. In between, there's some collagen substance. That's what all this pink, what's called hyalinized material is. But you can see the very distinctive pattern that's represented in the slide by Teflon and multinucleated giant cells, which altogether represents a granuloma. This pattern is represented and repeated in many, and I will get to the almost all specimens that we found in patients with recurrent trigeminal neuralgia after Teflon MVD when their Teflon is removed. And again, you can see right in the center of the screen a great example of a Teflon fibril with space around it because it doesn't attach to the collagen, but the attacking, if you will, macrophages have fused into one giant cell here, and that's what the multinucleated giant cell attacking a foreign material is that comprises and constitutes a foreign body granuloma. Now, if we look a little deeper into the composition of what happens to the Teflon, here are two pieces of Teflon, separate specimens from the same patient who had more than one piece of Teflon inserted. And again, you can see that fairly standardized pattern. You can see the Teflon fibrils. You can see the multinucleated giant cells in association with those fibrils, as well as a few scattered individual macrophages. But you also see a bunch of these little red cells. These are red blood cells. Now, this is a contaminant. This isn't hemorrhage into this tissue. This is blood that, so to speak, has spilled into the tissue during the extraction process, if you will. And as I said before, this is not a large amount of hemorrhage. It's a little bit of blood. A drop of blood would have this many red blood cells in it. But there's not a particular pattern to the distribution in the surgical specimen, just a bit of contaminated with blood. This picture represents a different phenomenon. Again, pieces of Teflon, it's the same specimen, multinucleated giant cells associated with the Teflon fibrils, scattered inflammatory cells throughout the tissue, and this structure. Now, when we talk about blood vessels, we talk about things like little capillaries, which are typically small enough that they allow only one red blood cell at a time to go through, so to speak, in single file, in the 7 micron to 9 micron range. This structure here contains much more than a single file of red blood cells. This is a new blood vessel that has formed or grown within the granuloma. This is angiogenesis or neovascularity, similar to what we see when tumors are growing inside the body or inside the brain, in particular, for let's say some malignant brain tumors. So this process of tissue aggregation of the phenotype of a tissue mass can actually have the growth of vasculature within it. Now you can see, and again, the specimen, this is a repeating pattern. This isn't just a one-off. And when you look carefully, these channels, these blood vessels, these small blood vessels, have all the characteristics of a well-formed, organized blood vessel. They are more than just the diameter of a capillary. Their lining, just like any normal blood vessel, is comprised of a thin, flat cell called an endothelial cell, specialized differentiated cell, and that constitutes the inner wall that allows blood to flow without clotting. So this is pretty organized for something that really doesn't exist in the body, the granuloma, and now it's growing its own blood supply. So let's get back to the Teflon that I showed you before. This is a piece of Teflon meant to displace a blood vessel that was pushing on the trigeminal nerve. You can't see either clearly here. You will in a second see the trigeminal nerve. Now you can begin to take it out and you begin to see the uncovering of the trigeminal nerve, which is here. Same orientation as I gave you earlier on. What you see here is some residual Teflon fibrils, but you see here a piece of tissue. This yellow tissue is part of the granuloma. This is the white blood cells, those macrophages, those multinucleated giant cells, aggregated now not at the microcellular level, but at the macrocellular level. You can actually see they have a physical mass, a physical form dispersed within the Teflon fibrils. And you can remove the Teflon, as you can see here. It's been pretty much extracted from this specimen. The trigeminal nerve is what's left after having been compressed by the Teflon. And you can see a few Teflon fibrils left, but pretty much the Teflon felt mesh network has been removed. And when you do this, when you do a Teflon removal or Teflonectomy, as we would call it, you can get sidetracked by removing the Teflon and not looking for other causes of recurrent facial pain, because again, these are only all symptomatic patients that have recurrence of their facial pain. So you need to look for vessels that might have been missed. So did the prior operation miss a blood vessel that's still compressing below the trigeminal nerve? or did one slip back into place around the Teflon, or did the Teflon migrate? So it's not just removing the Teflon to help patients who have recurrent trigeminal neuralgia after past MVD. It's removal of Teflon and still exploring for missed or recurrent vascular compression. So there's none below the trigeminal nerve there. A little suction tube is here. We're looking above the trigeminal nerve similarly to make sure there's no residual vascular compression. And when you find that there is none, this looks pretty good, although you can even clean up a bit more. And at this point in time, the surface of the trigeminal nerve, I don't think is impacted as much by the surgery as it was impacted by the chronic compression by that Teflon. But if you recall what a healthy trigeminal nerve looks like, it doesn't look anything like this anymore. So that's, the impact of putting Teflon in does have an impact on resting on the nerve. It does have an impact by being a foreign material and eliciting a granulomatous reaction or the invasion of monocytes, which become macrophages, which fuse due to their frustrated phagocytosis. And again, this is what it normal looks like. And if you use a Teflon-free MVD with a sling, you would be moving these blood vessels off and not leaving anything touching the nerve. So to further investigate what this granuloma is and what it looks like, we can start by looking at another piece of Teflon here and taking a surgical specimen and examining it in a little bit more detail than just the obvious. So when I say just the obvious, this might be the obvious site where you see Teflon fibrils and inflammation because of all the dark cells. But let's compare it to a section of the same specimen from the same patient at the same time, and let's look at what we see. So in looking at those two sections of the specimen, in this section, you'll see, again, Teflon fibrils. You'll see a lot of inflammatory cells. These are all monocytes that have become macrophages. You'll see a couple of clustering into the giant cells here and here around the Teflon spaces. And again, you see this collagenous material. This is a typical fibroblasts and what is constituting also some degree of scar tissue. When you look at the other area of the same specimen, what do you see? Contrast the difference. Do you see any Teflon in this specimen? No, it just happens to be a specimen with the scar tissue without Teflon. Are there inflammatory cells like there are here? No, we see different cells here. These are very flattened, elongated cells known as fibroblasts. Fibroblasts are what produce normal scar tissue, the collagen that you see that makes up this hyalinized ground substance. But you don't see Teflon, you don't see inflammatory cells, and there's no granuloma here. This is a very different section than here. So when we look at the pathology of specimens of Teflon that have been removed, there are sections that are, let's say, just say typical healed scar that are different than specimens that have granuloma in them. So if someone says, well, I took out my specimen and there was no granuloma there, well, if they just looked at a specimen that didn't have any Teflon in it, and they didn't see these little fibrils, they may not see granuloma, which is, again, the foreign body, the multinucleated giant cells, and the inflammatory tissue. Now I'm going to go through a video and I'll stop at a few different points, but this is removal of a piece of Teflon. Now this Teflon looks pretty good here. This has been in for several years. The trigeminal nerve is under here. You can't quite see it well yet. This is the facial nerve and the vestibulocochlear nerve, 7th and 8th nerve here. 5th nerve is down here. You don't quite see it. But we're going to see in a second, a little bit of tissue comes into view. And I just passed it. Go back up. Right about there. So if you look carefully, you'll see the Teflon threads, and you'll see little clumps, very subtle clumps of this yellowish stuff. And that's actually small pockets of early or small granuloma formation. And one of the things you'll notice as you remove Teflon, and I wouldn't say this is granulomatous at this stage, it does obviously contact the nerve, may exert some pressure on the nerve, but it is a bit sticky. And when we think of Teflon in the cooking world, obviously everyone thinks of it as non-stick, and non-stick Teflon is a phrase that was commonly used in marketing. This does get kind of stuck to normal tissues, and the adhesion process to adjacent tissues is not insignificant, and sometimes it can be very dense and difficult to remove. Sometimes, frankly, impossible without causing damage. So you have to assess when is the tissue too stuck to remove during its extraction process. Now, I'll advance a little bit further along to about 2 minutes into this segment, And again, you're seeing more of that little funky tissue stuff as we begin to do more dissection. But we'll advance it here to about 2 minutes in time. And now when we move this away, we begin to see a little bit more deep. Here's the trigeminal finally, and oh, wait, what is this yellow mass of tissue back here? You see Teflon that looks relatively uninvolved, not too bad. You'll still see little pockets of debris dispersed throughout, early little clumps of inflammation, early formation of granuloma, but you will see more significant components of granuloma. So as we watch here, as we begin to extract the Teflon, you see Teflon can be extracted. It typically can form a capsule and can be extracted from what's in its capsule, from within its capsule, if you do it carefully and slowly. But I'm going to advance again to get closer to that piece of granulomatous tissue. And right around here, you'll begin to see it being extracted. This is the trigeminal nerve. This is not Teflon. This is Teflon with a large mass of granuloma, or a significant size mass relative to what we're working with here. And it can be removed carefully, but as you'll see, we're going to pull it out, and with it are embedded Teflon threads. So this has grown amidst, grown within, or grown around the Teflon. I'll advance to the end of this little segment here. You can see that the Teflon's being pulled away from the trigeminal nerve, and the granulomas are pulled away from the trigeminal nerve. But as we extract this, you'll see there are Teflon threads that come with this. Let's advance it to about 430. And as we begin to pull both the Teflon mass here and Teflon is coming out with it, you'll see the characteristic little threads that are Teflon. And you've seen this before in the specimens. So this is what Teflon removal looks like, and that's what the granuloma is within that section of Teflon. Now let's look at a few more things. When we do our evaluations of trigeminal neuralgia patients, we have 7T MRI. We're looking at the different types of sequences, like the Fiesta sequence, like the KISS or CIS, the CISS, like the SPACE or SPC sequences. There are a couple of new ones that we're working on developing. But you'll see as I play the video, you'll see on the left a normal trigeminal nerve root entry zone, and you'll see on this side there's a trigeminal nerve coming out, and you can see a piece of Teflon. And I'm going to stop it right here because in the center of the Teflon, there's a little white spot, which is the enhancement within the center of the Teflon. We can talk about that later. And then as the trigeminal nerve moves forward, it moves towards Meckel's cave, and that's where it begins to divide into the three branches. But here you can see that foreign body. But one of the things I think it's good to appreciate is the beautiful clarity, the crispness of the vessels and the nerves in a 7T MRI. And again, you can see how this is against the nerve. There's a small vessel on the far side of the nerve, and I'll talk about what I mean by the far side of the nerve coming up, that it was ideally by the previous surgeon, the Teflon was placed to displace that. When we do surgery, you know, we come from back here over the surface of the cerebellum. We don't have to go through any brain to do an MVD. And we come along this CSF space over the surface of the cerebellum into the CP angle or just above the CP angle. And we approach the trigeminal nerve root entry zone here looking for vascular compression. So here's the root entry zone coming out. There's Teflon placed at the root entry zone and displacing this blood vessel away from the nerve. And I would presume, I don't have any preoperative images from this patient's surgery, but that nerve was against the blood vessel that was there was against the nerve. And I'll show that to you. You can kind of get the sense of a little blood vessel on the far side right there. And then here is the other blood vessel that's on the opposite side of the nerve where the Teflon has separated this, and maybe this is a small vessel from the nerve. That's what I would have to presume. Again, I don't have the previous op notes. These cases are sometimes 10, 20, or even 30 years ago that the patients are coming with recurrent pain, and we don't have the operative notes. So in a further clarification of what we can do, this is another patient who has Teflon on the far side of the nerve. In this picture, the trigeminal nerve is behind this forcep here. You can see it running with the blood vessels that feed the nerve. These are normal blood vessels that feed the nerve. And behind it is a piece of Teflon that pushed the blood vessel away. This is a different case. This is the case. This is actually the 7T patient that you just saw. And if you look, you're going to see Teflon that's very yellow and discolored. Now, this is the same piece of Teflon that's over here. that looks pristine. This is what Teflon looks like when it first goes in. Nice, clean, white. It doesn't look as this section does. So if I give you a still photo, this is one piece of Teflon inserted behind the trigeminal nerve by the prior surgery, displacing a small blood vessel away. This is the blood vessel behind the Teflon, pushing it away from the trigeminal nerve. But look at what's happening to the Teflon here. This is developing granuloma right up against the trigeminal nerve. So in this case, you can see here the Teflon has been extracted towards the right. It's been detached from its one of the points that it was stuck to here. This is the blood vessel that by the prior surgeon was felt to be causing the problem, pushed away, and now this Teflon can be extracted. This is what the trigeminal nerve looks like in this case, where you don't see very much artifact of compression. So this is a lot nicer looking trigeminal nerve compared to the first one that was compressed by Teflon after Teflon removal. So let's get to the kind of the nuts and bolts, the conclusion here. What is the significance of a foreign body giant cell? So I told you how they form. I showed you what they look like, but what is the significance of foreign body granulomas from a physiologic standpoint? So the foreign body giant cells and the macrophages, they create a privileged environment. This is all data from material science, from biomedical engineering work that studies what happens to any material, a hip, a pacemaker, a cardiac valve, when you put something that's non-organic into the body. The same reaction can occur. This privileged environment, as well as macrophages, are stuck to the surface of the Teflon that limits exposure of other activity like fluid that might wash away any debris. The adherent macrophages, which are stuck to the biomaterial, becomes activated, and we talked about this before, and it secretes enzymes that also attract other inflammatory cells that also want to magnify the inflammatory response because they're not getting rid of material that can't be broken down. Now, when I talk about frustrated phagocytosis, I said that's when, like an amoeba would engulf a piece of food, it wraps itself around it or encloses a foreign material to get rid of it, or a piece of debris or dead tissue. Frustrated phagocytosis, it's a fun phrase to say, but that's when you try and phagocytose, but it doesn't occur. It can't be done. But when you do that, you release mediators of degradation. So it releases enzymes that are going to break down tissue, normal tissue as well as bad tissue, because it keeps trying to get rid of the bad tissue. And these mediators of destruction are oxygen-free radicals, which destroy tissue, enzymes that break down tissue and create an acidic environment. Now, I digress for a piece of humor here. I talked about frustrated phagocytosis, and this is not as interactive as I'd like it to be sometimes, but this is a webinar, so I just get to broadcast, and I have to assume you're all raising your hand saying, you know what that movie is. So if you know that movie, that's great. I wish I could call on you to say what it is, but that's from the movie of The Blob. And, the Blob basically phagocytoses people. That was the terror. And it engulfs them and dissolves them. And that's the actor. If any of you know the actor, you can send it in the chat if you know who that is. All right, enough fun and games. We'll get back to the presentation. This privileged environment where you're having these digestive enzymes being released, and the privileged environment where the giant cells are stuck to the Teflon, it reduces any flow of spinal fluid to perhaps wash away some of these enzymes. There's no buffering. There's no mediating that acidic environment. You want to try and get rid of an acidic environment by washing it away. That doesn't happen because of the adhesion of the giant cells to the surface of the Teflon. And this foreign body reaction that we talk about, creating giant cells and recruiting more white blood cells, persists for the life of the biomaterial. So as long as Teflon's there, the slow process of trying to break down tissue, an oxidative process, is continuous. It's at very low levels. It's a very slow chronic process, but it's ongoing. Now, one of the interesting things I mentioned before, that the use of Teflon and the use of implants have been studied extensively. From implants, one of the most studied devices is the cardiac pacemaker. And what's really studied is the part that fails in cardiac pacemakers, not the titanium cage, not the plastic connection, but the wires or the electrodes that go to the heart muscle. And the part that gets degraded is the insulation around the wires by foreign body giant cell formation, and the degradative environment breaks down the flexible plastic, because these leads need to be flexible. Foreign body giant cell reaction causes destruction of that insulation and that's where the failure occurs when pacemakers need to be replaced. So in summary, I'm trying to stay on track here. Biomaterials like Teflon produce a complex series of reactions, including both chemical mediators, leukotrienes, and other devices, like I said, oxygen-free radicals. And they also, that's the medical side, if you will. And then there's the cellular elements of inflammation, the monocyte to macrophage to giant cell continuum. The chemical responses include protein absorption, chemotaxis, cytokines, leukotrienes, interleukins, many other complex proteins that are inflammatory and degradative or digestive, if you will. The cellular activities I outlined include cell migration, adhesion, activation, differentiation, and fusion. And the formation of a multinucleated foreign body giant cells produces a unique environment that's degradative or digestive. It's trying to get rid of this material because it just doesn't recognize it as normal part of the body. What's the clinical relevance? So, as I stated at the very beginning, trigeminal neuralgia is a condition that is incompletely understood. I didn't say poorly understood, but I will certainly advocate for incompletely understood because there are cases where we don't understand what's happening. Now, we do know that most MVD surgeries are initially successful with Teflon. A high percentage, clearly a majority, are initially successful with Teflon. But there are an unfortunate number of recurrences which occur, which are not insignificant. Ask half the members of the FPA, and subsequently can be resistant to other treatments, as the case example I started with. Now, the bioreactivity of Teflon and granuloma formation has been documented in multiple case reports, not only of trigeminal neuralgia and Teflon granuloma after MVD, but in multiple other surgical settings. And I'll give you two very specific examples. When Teflon first came out as a, so to speak, slippery substance, non-stick substance, it was thought to be a great tool for hip implants and specifically the hip socket. And they began to make hip sockets out of Teflon, and they had to very shortly after that stop it because it began to form granulomas and form tissue destruction because of the digestive environment that surrounds Teflon granuloma formation. And if you go research hip implant history, you'll find that that's very early on and a very profound reaction. The second very clear example was the use of Teflon for temporomandibular joint replacements. There was a product called a ProPlast implant made of a piece of Teflon where you thought, oh, the jaw joint with a mandible, the top of your jaw, would insert into a little socket. That's the temporomandibular joint. And they put a little Teflon pad thinking it would glide, hiding or repairing arthritis that can occur in the TMJ. They found that they had the same problem: bone dissolution, bone destruction, tissue destruction, and foreign body granuloma formation due to Teflon and the foreign body reaction. But in spite of the evidence that Teflon as a biomaterial is not that inert, it's slow, it's chronic, it's not a very acute reaction. It is a chronic reaction. It takes years and potentially decades. It does continue to be utilized in most MVD surgeries in spite of all this evidence. Unfortunately, what happens is we are stuck discussing how to treat recurrences. Now, this presentation was not about outcomes, was not about causation of, per se, Teflon granulomas as a guaranteed direct causal cause or direct causal etiology for recurrent trigeminal neuralgia. But I'd argue that it should be thought of because of the evidence that I just presented. And the clinical relevance is that we have found Teflon granulomas to be histologically confirmed in about 95% of cases operated on for recurrent TN. Again, pain that's come back after prior Teflon MVD. It doesn't say what's happening in patients who have successful Teflon MVDs. We're only talking about patients that do have recurrent pain, have a very high association of granuloma identification. And the question is, could this be unique to the recurrent pain patient? Because obviously we don't do Teflonectomies on patients that are doing well. So it's a bit of a problem to try and solve that question. However, there are other techniques such as a Teflon-free MVD that the use of Teflon MVD surgery deserves to be re-examined given the reality of occurrences and at least the consideration that maybe it would be better without Teflon now that we have better surgical technique than when it was initially described in 1965. We've made advances in microsurgical technique. We have advances in lighting and microscopes and in the understanding of what Teflon actually can cause long-term, not acutely, but long-term. And really, we should be having a discussion of how to prevent recurrences so they don't occur. And we should not be having a conversation of how to treat them when they do occur if we can improve. Thank you.
Thank you so much, Dr. Zimmerman, for that incredibly informative presentation. I'm sure, as you can see, there are many, many questions coming through our Q&A, and we also had several that were sent in advance. So I'd like to get to as many as we can
Oh, good luck.
this afternoon. Absolutely. Um, the first question I'll ask is, can you explain the difference between a calcification and a granuloma?
Sure. So calcification is also the response of the body to chronic inflammation. One of the things that can happen with any kind of inflammation is the deposition of calcium deposits. So let's say you have chronic injections, a very simple example, or if you have to take medication and you do an intramuscular injection, one of the things that can happen is the development of calcium deposits at the site of the injections. If you get a splinter and it doesn't get healed, sometimes you can get calcifications around that, but that's much more rare. Calcification doesn't typically occur in the skin. There are inflammation in the brain that can occur that results in calcification. Certain infections over a chronic period of time cause calcification. So the deposition of calcium is one response to inflammation. The calcium in and of itself is not inflammation. A granuloma is actually the inflammation occurring. It's an inflammatory entity in and of itself. Calcium is a sign or product of inflammation. The granuloma is actually inflammation occurring. I hope that helps.
Thank you for answering that question. Here's another question that came in advance. You mentioned during your talk that, granulomas are giant cell immune system reactions from inflammation. Um, and cranial nerve systems from this process tend to be nerve dysfunction rather than stimulatory hyperactivity. So, in the context of, for example, the seventh cranial nerve as opposed to the fifth cranial nerve, the very rare case of Teflon granuloma tends to be facial weakness and not necessarily hemifacial spasm. In the case of the fifth cranial nerve, the trigeminal nerve, would you expect, or wouldn't you expect numbness rather than pain? And is there any evidence to suggest that a Teflon granuloma can lead to nerve hyperactivity?
So again, this is an observation that's part of my interest. I don't want to get to the point of drawing causality between any of this because that has not been established. I don't pretend that there has been. I just think that, we need to entertain the question of, are there potentially different ways, putatively, hopefully, or maybe better ways of doing things as opposed to doing the same thing over and over again without making improvement for our patients? So if we have a possibility that an inflammatory process, which we know is irritative, is discovered during exploration of patients who have recurrent pain, maybe if we didn't have that inflammation, they wouldn't have recurrent. And that's the argument that I make. The issue of, does inflammation cause activation of a sensory nature versus a motor nature? That's an interesting question, although I would say we really don't understand the differences between trigeminal neuralgia and hemifacial spasm. And I'll give you two very specific examples. In hemifacial spasm, we really find that medications that work for trigeminal neuralgia do not work for hemifacial spasm. So the carbamazepine, the oxcarbazepine, the typical drugs, the sodium and the sodium channel blockers that work as anti-epilepsy drugs for stopping trigeminal neuralgia do not typically work for hemifacial spasm. Yet we think it's the same mechanism, but they don't work like that. The other example is the opposite. Why, when patients have trigeminal neuralgia, why don't they have, if you will, hemifacial spasm of their muscles of mastication? So the trigeminal nerve has a motor root, just like the facial nerve is a motor nerve. And yet when we see the trigeminal nerve manifesting trigeminal neuralgia, we don't see trigeminal neuralgia manifested as a hemimasticatory spasm, if you will. So we don't see that. So there's not exactly a perfect analogy between the two. So I don't think it's easiest to make that kind of assumption of why it's different for one or the other.
Thank you. Thanks for answering that question, for also providing the context of there being the motor and sensory components of the trigeminal nerve for the patients who are listening today. Here's another question. What are the symptoms that you hear from patients when a patient has a Teflon granuloma?
So, what we don't know is how many normal patients that have had successful MVDs have Teflon granulomas. So obviously, the problem is when a patient does well after an MVD, they don't get reimaged. We don't see anything like, we don't look for enhancement because we don't get an MRI. Not that enhancement necessarily means there's a granuloma there, although it is certainly suspicious. And we don't image patients that don't have pain. So we certainly don't go in and operate and take the Teflon out just to say, you're a normal patient doing well. Do you have a granuloma and are normal and pain-free? So we really only have half the equation. And until something arises like imaging or some other measurement of pain that's non-invasive, we may never know what's happening in the patients who are doing well. So I think that that is one of the biggest obstacles in trying to understand what's happening. The symptoms that patients have with granuloma, I can't comment. You have to look at the question a different way. I would say that patients that have pain need to be recurrent pain need to be considered to have a granuloma.
I see. I
You
see.
can't look at
So
it. You can't. It doesn't work the other way around. You can't say what are the symptoms of granuloma. The only symptoms of trigeminal neuralgia are trigeminal neuralgia symptoms.
thank you. Thanks for explaining that. Here's another question. Can this person might be a medical professional, I'm not sure. Can we use resorbable collagen instead of Teflon?
So that's a great question. And the real issue is let's find out. So if you have something that dissolves, like I like to use fibrin glue, which dissolves and gets broken down by the body, and with vascular transposition, arachnoid healing or arachnoid scarring or arachnoid growth, the normal process of what happens when you do surgery and move things around, if the collagen goes away, and the blood vessel stays displaced, which it most likely would, because once you move it and attach it to, let's say, the dura or some other structure, it will likely grow adhesion and scar tissue to that, especially if you facilitate it with glue, because you make it adhesive at that point. But certainly, if a collagen tissue dissolves and is not present anymore, I suspect it may not cause a granuloma. One of the things that's interesting about Teflon was, Teflon felt was initially chosen because I think it was felt to be soft and remoldable, and you can fluff it up, if you will, if you will, a little pillow, if you want to make an analogy. But I think that may be part of the problem because the interstices of the nature of felt has little nooks and crannies that you really can't get to. The body can't, let's say, wash it away with spinal fluid. And I told you that the white cells move like little amoebas. And I think people don't understand how mobile they are. But you have to think about how do all the white cells get to a pimple? How do they get to an abscess? How do they get to infection? They're mobile. They crawl or they exert pseudopods. They have cilia. They do, and I don't know which of those mechanisms they do walk by, but they do walk and they do migrate. But I think that they get into the little nooks and crannies of a Teflon felt mat. And I think that's one of the reasons why it might even be preferable to use a solid piece of Teflon like a piece of plastic, even though it's hard. Although the whole issue of pulsation, I can get into a lot of digression into the pulsation of the vessels, so it's causing a problem on the nerve. And if you have a hard substance, it's going to transmit pulsation, so it's not an improvement. We don't know. I mean, there's a lot of things we don't know if that's the real cause of why vessels activate the nerve to make it short circuit, if you will, and have pain in the presence of loss of myelin. I mean, there's so much we don't know. We have a lot of hypotheses, but not a lot of hard knowledge.
Thank you. Here's another little bit more technical question that came in. So, like any foreign body, PTFE, which is polytetrafluoroethylene or um,
Teflon. You can say
Teflon,
Teflon. Yeah.
yes. It can result in an inflammatory response to varying degrees. And because of that response, it can show an enhancement of PTFE on an MRI after an MVD as a normal finding. Have you found variations in the composition of granulomas depending on the manufacturer of the implant? So, for example, Teflon is made by Chemours, but there are other manufacturers that make similar products. If the implants are causing granulomas leading to the recurrence of TN, why do some studies, and they've quoted one there, which is UHL et al., with the nerve of PTFE, not find kind of a superiority of transposition over interposition?
Okay, so that question has multiple questions.
Okay,
And
yes.
I'll attack the two major ones, which I think the requester is asking about. One is different kinds and makes of Teflon. So obviously we don't know. When we do Teflonectomies, I have no clue what manufacturer was used. I bet you the surgeon had no clue what manufacturer was used. It varies by hospital. There probably are only a number of places that provide, medical grade Teflon of the type that's typically used in MVD. Most of it, I think, probably is the biggest in the cardiac industry and the vascular surgery industry, where those pledgets are used to sew gentle tissues together and help seal them from leaking. So we really don't know what different manufacturers. We have begun some research on sending away a piece of the Teflon that we use here for some chemical analysis and trying to understand what's the chemical composition. But I don't think that's the real issue with most of the Teflon. I think it's recognized as foreign. And like I said, all the other biomedical literature about Teflon in hips, Teflon in TMJ replacements, they just discuss the PTFE. They just discuss the fact that the Teflon itself is not recognized. It's inorganic. It's recognized as farm material. It can't be broken down because it's farm material, and it causes this fairly stereotyped farm body giant cell reaction. Um, the second question is, why did one study not show a difference between transposition and decompression with Teflon? And so there are two studies that could be referenced. One is the Yule study, and the other is a study by Mark Sindo that has about 3 times as many patients as the Yule study, where they did show the advantage and the superiority of a non-compressive decompressive technique compared to one where Teflon is left in touching the nerve. The interesting thing about both studies, they both used Teflon on both cohorts. So they didn't look at a non-Teflon cohort in either study. Now, where they say they didn't find Teflon, I've given you great examples and wonderful pictures, at least in my mind, of how the same piece of Teflon can have no granuloma on one side and a florid granuloma on the other. So when you say you don't have Teflon granulomas, I think it's important to say, well, how hard did you look? Where were you looking? And not all Teflon results in granulomas because, like I said, patients that are perfectly well, the response may vary by individual. Individuals may have different sensitivity to Teflon. There's just so much that we don't know. We know that some patients are allergic to peanuts and others are not. I don't think Teflon, and I don't want to make the exact analogy to an allergy. Analogy to an allergy, that's hard to say. But the bottom line is, we don't know if there is a sensitivity to Teflon in the spinal fluid against the brain in various patients. So how reliable? We know that most patients do well with Teflon initially. But we know as time goes on and this chronic process of inflammation can occur, the recurrences do occur with greater frequency the farther out you go from the date of surgery.
Thank you. Thanks for answering that question so thoroughly. And I know it did have multiple components, so I
Mhm.
really appreciate that. Um, Here's a question about what test would be done to see a granuloma? So an MRI, an MRA, a CT, or is there a special type of test that can image that?
So again, because we don't have, so to speak, normals where we do a scan, we find out whether, let's say on an MRI, there's enhancement or not enhancement. And if the patient's, having pain, we take them to surgery, we might want to take the Teflon out, and we can analyze that. If the patient's not having pain, number one, they wouldn't be imaged. Number two, they certainly wouldn't have surgery. So it's really hard to say because if that patient who doesn't have pain does have a granuloma, how are we going to know? So that's one of the limitations. But in patients that have granulomas, we do see a variable degree of enhancement. But again, that enhancement may be related to that neovascularity that I talked about. So the blood vessel that the Teflon can sometimes grow. Now that's not common. I will say that in numerous number of granulomas that I've looked at histologically with the pathologist, it's rare to find neovascularity. It's not common, but that might be one cause of enhancement. And like I said before, we see variable degrees of granuloma in different parts of different pieces of Teflon. And I've taken out Teflon where one piece, some surgeons put in many pieces of Teflon, and one piece will have a granuloma and the other piece will not. Again, the whole point that I'm trying to make is because they do have a granuloma and they do have pain, should we question whether there's an association? And again, if we're trying to improve, even if it's 3% or 5% less patients with recurrence by not using Teflon, is that a reasonable goal to try and figure out a way to not use something that has a 5% chance of having a granuloma in the future? Just trying to make things better for the patients.
Thank you. And thanks for providing that context of, you had shared earlier that you're talking about patients who have had the recurrent pain. In those, that's where you're seeing the granuloma tissue form.
Right.
So, Here's another question that came in earlier. So, when you remove a Teflon implant with the felt being, stuck to the nerve, could you be causing kind of an unintentional injury or a rhizolysis? So, if you're having, a rhizotomy done for the pain by removing the implants, could that be a possible explanation for why some of the patients feel better, at least temporarily, after removal, but may not have durable pain relief?
Absolutely. So again, my favorite phrase, trigeminal neuralgia is something that's incompletely understood. When we do a microvascular decompression, people wonder, well, are you just traumatizing the nerve by a standard MVD by stuffing the Teflon in there? And that manipulation of the nerve, whether it's enough of a rhizotomy to cause the pain to go away, even though it doesn't cause numbness, those subtle rhizotomies because we do know that sometimes rhizotomies don't cause numbness, whether it be glycerol or let's say radiofrequency or gamma knife. Sometimes they don't cause numbness. So certainly peeling Teflon off the nerve is manipulated. Could there be enough trauma to the nerve to cause ineffective rhizotomy? Absolutely. There's no question about it. But the point is, why bother putting the nerve through that in the first place? If you don't put Teflon on the nerve, you won't have to traumatize the nerve.
Thank you. Thank you. Um, there's several questions. We still have 44. So we won't be able to get to all of them today. However, I can provide them to you in a document, but it's very popular conversation today. So someone asked, I have a Medtronic stimulator. So this is somebody who, it's has facial leads, would they be able to have an MVD with Teflon removal? So I'm not sure if they're asking if they could have their Teflon removed or if they could have an MVD without Teflon. I'm not certain of the question there.
Yeah, so let's take both cases so they get their answer.
Yes.
So let's say they haven't had an MVD and they tried something else a little less invasive first, so peripheral nerve stimulation. So in order to have an MRI, if you haven't identified vascular compression, you haven't identified the posterior fossa anatomy, you may need to have the stimulator removed before you have the MRI. And then have an MRI because I think most surgeons would like to have the MRI if we're going to go in if it hasn't been looked at already. On the other hand, I would assume that probably most patients that have had facial pain that are at the point of getting a peripheral nerve stimulation inserted have had an MRI. And if it's good enough to look for vascular compromise, then there's nothing per se about having a stimulator in place that precludes them from having surgery for their initial MVD, nor does it preclude them from having surgery for a Teflon removal MVD or Teflonectomy. But again, one of the things would be, have they had an MRI? If they've had an MVD in the past, have they had an MVD, excuse me, have they had an MRI after the MVD, but before the stimulator was placed? It's something that the surgeon would have a roadmap on since the intracranial surgery. So that would be the real question. If they haven't had something done since their MVD, if they've had one, we would prefer to have a look at see what's going on to know what we'd be getting into.
Very good. Thanks for answering both sides of that question. It's very helpful. Here is a question. Are there situations where a person with TN is not a good candidate for a Teflon-free MVD? So you had talked about in your talk, those who are having either the Teflon removed, but this is just, fresh MVD, not with Teflon. They said, for example, can an artery compressing the nerve have so many tentacles or feeders coming off of it that the artery would keep snapping back or would not move without the risk of causing a stroke? In an instance such as this, would using Teflon be needed? Or are there situations where you can't do a Teflon-free MVD?
Yeah, so I think it's a great question, and I get this not infrequently. I am not a absolutist. I like to have an open mindset and always think, well, what options do I always have? And while Teflon granuloma, and we talked about this, I mentioned it that it occurs in a lot of other things. Anything that gets implanted might have some degree of foreign body giant cell reaction to the implant. If I had to use Teflon, and I have used Teflon at times, but it's probably a handful of cases in my career, I just want to make sure it's not touching the nerve. So if if you really can't do a Teflon-free MVD for whatever reason, and you have to put something foreign in someone's head, and you have their consent to do that, because most of the time when we have our conversations, at least here, at Mayo, when I talk to them, they come saying, I don't want anything in my head. So you have to make sure that you have their permission to use Teflon if you need to. But if you put Teflon into, let's say, transpose a vessel, you can do that. I would certainly not have the Teflon anywhere near any of the cranial nerves when it's sitting in. You would want to make sure it's not going to move there. Although there are other options that avoid the issue of Teflon and the felt matrix or network that provides a little hiding place for all those granuloma cells to grow. Aneurysm clips, other adhesive agents are both available that might be preferable to Teflon. I don't know if there'll ever be a point where we can study a non-felted Teflon implant to see if that's superior to a felted Teflon implant for MVD. Because it's certainly nice. The Teflon implant type of MVD is certainly simpler than a transposition. It's a little less dissection or a lot less dissection. You have to think about the mechanics a little bit less. You have to, since you're moving the vessels a bit less, you have to worry a little bit less about perforator mobilization. And again, many surgeons who do MVDs aren't really trained as microvascular surgeons. So they do a few a year, or they do one a year, or maybe one every 5 years, and they're really not, trained in. They do a lot of other brain tumor surgery, but it may not be microsurgery, it may not be microvascular surgery. The Teflon-free technique with mobilization and transposition is a little bit different operation, and it takes a little more practice, dedication to do it more than once a year or something like that. But there are other things like aneurysm clips and slings and Tacoseal, which is an adhesive collagen-based product that might be better. But I don't know if we're going to ever have the chance to study that.
Thank you. I did see a question, something about the sling, so I appreciate you addressing that without me having to ask the question. Um, when you say long-term effects of Teflon, can you give an estimated time frame? So there's been a couple of questions in the Q&A about, how long after an MVD are you seeing these granulomas form or having to go in and do surgical procedures to remove them?
It's a great question, and obvious why someone wants to know. The problem is we have no clue because the patients live with their recurrent pain for many years. We don't see a lot of them. We don't know who has, a granuloma or doesn't. As I said before, one of the great unknowns is we don't know how many normal patients without pain are walking around with granulomas. So, if that's the case, because I'm not making the case for causality of everybody gets granuloma or only recurrence, patients get granulomas, we just don't know. I can only tell the association of patients with pain that finally present to have enough, so to speak, courage, or they're desperate enough to have more surgery, or they're interested in getting off the drugs so they get out of zombie land, um, to consider more surgery, or they even are told that more surgery is an option because many patients, that one of the battles that we face at the FPA, at least the surgeons feel that is, many patients aren't even told that there's a surgical procedure that can cure them from the start, and they're kept on drugs for a long time. That's problem number one. They have they have an MVD, and that's great if they do well. If they have recurrence or they don't do well, then people will say, well, you had your surgery, it didn't work, that's not for you, go on to the next thing, gamma knife or rhizotomy. But unfortunately, repeat surgery is an option. You have to just debate what the pros and cons are for the individual patient, what their preferences are. Are they willing to undergo another more operation, that's invasive versus a less invasive operation that's, let's say, percutaneous or radiosurgery that's non-invasive but has other side effects and other potential complications? So it's a little hard to say. The patients that we see come from, within a year I had surgery, my recurrent pain is back, and I go in and I have a granuloma versus I'm here 30 years later and I have a granuloma. I honestly can't tell you how long it takes. We just know that the process from other materials, from the science and the materials engineering outside the Teflon MVD world tells us this is a chronic process. It's not acute. It doesn't occur in the first week. And this granuloma formation in general in the pathology world is a chronic process, not an acute process.
Thank you. I want to be respectful. You've been so generous with your time. I'll ask a couple more questions and then we can wrap up. So, here's one question. For those of us with anesthesia dolorosa, which is described kind of as this painful numbness that can occur more often after ablative procedures, but some people do experience it after having a microvascular decompression. Could our 24/7 chronic pain be due to a granuloma after a failed MVD?
So when I talk to patients that come to see me with recurrent pain, either after failed MVD or recurrent pain after successful MVD, I do tell them that I don't think I can improve the anesthesia dolorosa component of the pain with Teflon removal. And those patients that I choose for surgery, I really dive into the history, say, how much of your pain is burning? How much numbness do you have? And how much electric shock like or attacks of exacerbation of your pain? Even if it is burning, if it fluctuates with acute sudden onset of, an attack, if you will, an episode, that those components have a greater success rate. If it's a fairly constant level, it's just always hurting, always hurting. Sometimes it's worse, but it's always hurting, it's always hurting. I'm not optimistic, and I typically won't do removal of Teflon or repeat MVD for those patients because I haven't been successful early on, and I don't think there's literature to support anesthesia dolorosa being cured by either repeat MVD or Teflon removal. So I just haven't seen that, and I'm sorry for all those patients that are suffering because that is a tough one that we're really looking for a good answer for.
Thank you. Thanks for providing that. A final question would be, some people are asking, how can they reach out to you, or if they have more questions or are interested in learning more, where would you recommend they go?
Well, I put my email address on the slideshow, so if you weren't paying attention, I'm sorry. No, they can always go through, the FPA and stuff. Or the better way is to go to the conference in Minneapolis in June. You can give them the dates. It was a cheap plug, but I figured I had to get it in somewhere.
Yes, June 7th and 8th, we'll see you at in Minneapolis at the University of Minnesota.
But let the rest of the audience members know that's the annual first in-person as well as remote conference held by the FPA in conjunction with, I think, three universities.
There are going to be several. And so we are working on finalizing the details and the speakers, and we will be sending out more information in our bulletin. And I appreciate very much the plug there, Dr. Zimmerman, and sharing with everyone in the audience today. And we do hope to see all of our patients. As Dr. Zimmerman mentioned, this is the first in-person conference since 2019, and we are thrilled with everyone who has already offered to come and speak, and looking forward to inviting more. Let me see here. Let me ask you one final question before I let you go. Um, how long does it, oh, that was a granuloma forming. So have you had success with Teflon pad removal, um, improving after somebody's had an ablative procedure? I apologize, it was two questions. So somebody who has had an ablative procedure, could they have granulomas form from the ablative procedure?
Yeah, so great question. Because a lot of patients do choose to have a less invasive procedure, which are the ablative options. And yes, so again, what we're looking for an MVD, at least for my practice, patients would have trigeminal neuralgia pain, that is the typical attacks, distribution, lancinating, sharp stabbing pains that have exacerbations. They can have what we would consider TN type 2, where they do have some component of pain that's a lesser degree, but they still have the sharp attacks, so to speak, an acute episode. We've had patients, I said before, the anesthesia dolorosa, I don't give them optimism about getting rid of their numbness in those cases. But in patients who have had an ablative procedure and have had numbness, but not anesthesia dolorosa, they've had return of some sensation. So I won't say that they've gotten back to normal, but after Teflon removal, if they've had numbness from either their prior MVD or MVD with an ablative procedure, they come and get a Teflonectomy. They've had improvement in their numbness. So that's definitely happened in our patients. So they've definitely, because they tell me they wake up and said, I can feel my face for the first time in X number of years. So that's number one. I do want to make one other point about MVDs that you did bring up earlier about MVDs with rhizotomies, whether it be combing, squeezing, stroking, neurolysis. A lot of surgeons will do two things at the same time. And there's no real argument for or against this, but I will tell you that people need to understand that. You do an MVD, you move the blood vessel off the nerve, Teflon or otherwise, that's part A. Some surgeons do a part B all the time or selectively, which is somehow doing a rhizotomy. You can call it what you want, but if you comb the nerve, you pinch the nerve, you stroke the nerve, and surgeons use a lot of different euphemisms, but basically you're doing a mechanical rhizotomy when you're at surgery. assuming you're even gentle with the nerve when you do the decompression, putting the Teflon in, they still go in, and some would even cut the nerve, do a partial sensory rhizotomy by just cutting a small section of the nerve, like Dr. Giannetta did with his initial MVD that he published in 1965. He did both. But we have to realize that the patient should be understanding that at least they should ask, am I going to get a rhizotomy? Will I have some numbness? Because ideally, the patient is told for an MVD, you preserve normal function. And we see a lot of patients that wake up and said, oh, I was numb when the surgeon told me that, oh, yeah, I combed your nerve. So, well, you should have told them that before the surgery. So just be aware when you have your surgery that and be explicit about, are we having an MVD or do you also do a partial rhizotomy or combing or stroking the nerve? And sometimes that can improve the success rate at a cost. It just depends on whether you think you found real compression or not. Sometimes explorations go when you don't find obvious compression. And at that point, a rhizotomy might be the best option. If it's just a venous compression and it's not dramatic or there's no indentation or it's really not very impressive, it's hard to know whether that's due to brain shifting, CSF drainage, and surgical positioning and manipulation, or if in fact there never was any compression. And if you don't do something other than just exploring, they will wake up the same way. So there are issues, but again, that point needs to be clarified. And one of the problems we have with outcomes is when you see recurrent patients that I see, let's say for Teflonectomy, Teflon removal, they've had so many variations in how their first MVD was done. They've had multiple procedures. After the first MVD, they have rhizotomies and radiosurgery. So it's a very heterogeneous population. So you read large numbers when the base population is very mixed in terms of its substrate or starting point. You need to have huge numbers to really make a fair statement of this is what we find as a pattern or a conclusion. So it's very difficult. And again, I always go back to Dr. Zaksevska's article on how challenged we are to use good assessments of our facial pain outcomes. Because the population varies a bit, our questions are a little bit on the cheapo side in terms of being in-depth and pre-planned and rigorous. And then we need numbers and that those are the realities of a good science, so to speak.
Yes, and that's a very important point. And something I'll mention also is that the FPA will be launching a patient registry in 2025 here in the next few months. So please stay tuned for that as well. And there was one question I want to address that was in the Q&A. Someone was asking where they could go to get basic information from the FPA to help guide their spouse who has facial pain. If you go to www.facepain.org, we have information and resources available to help support you. Not only additional webinars, but also quarterly journal articles, as well as support group meetings and one-on-one peer support. So you can go to facepain.org and subscribe to our newsletter to receive information and resources about everything discussed today, including recording of today's webinar, which we can include, Dr. Zimmerman, your information on that card so that they have it available. And I want to thank you all for joining us today and thank Dr. Zimmerman for your generous time.
Thank you for having me and good luck at the conference in June.
Thank you so much. See you there.
Bye-bye. Bye-bye, everybody. Thank you.